thank you for being here, Captain. You may or may not know I'm a physician, worked 25 years in a public hospital for the uninsured, similar to what Temple did, except we were really uninsured, Medicaid, poorly insured. And so I understand very well the importance of 340B. But I do think it's important to move beyond anecdote, because everyone quoting articles, quoting hospitals in their district, of course, the hospital has a vested interest in the program maintaining as it currently is. Senator Murray, in her opening statement, I think I recall, said that people are alleging that it's actually raising the cost of insurance. But if I recall, oh, I thought you said that, I apologize. But because it is, but that's not an anecdote as best I can tell. I just want to move beyond the anecdote, if you will. For example, there is a February 2016 blog published in the New England Journal of Medicine from the University of Chicago, in which the person speaks about how reports suggest that the original program has substantially expanded in recent years to include newly qualified entities, affiliated clinics, certain contract pharmacy arrangements. It is currently so vast that commonly infused or injected drugs by patients, their prices are probably being driven up for all consumers. As pharmaceutical manufacturers face substantial and expanding demand for discounts, they can and do pass the cost of these discounts on to other payors. So if you have commercial insurance, you're paying more because of 340B. Again, a blog post from the University of Chicago. Secondly, to point out is an article from the New England Journal of Medicine, which as a chair I will submit for the record and so approve, in which they find that 340B entities are buying physician practices. They have an overrepresentation of physicians that infuse drugs, that the cost has been elevated. Importantly, the poor patients, the Medicaid patients, are seen less frequently as a percent of their business than in the non-340B. Counterintuitive, but the more you go into business of providing 340B, proportionally the fewer Medicaid patients you actually see. And importantly, they also said that the financial gains for hospitals have not been associated with clear evidence of expanded care or lower mortality for lower income patients. As a doctor, this means a lot to me. We have raised the cost of care. There is no improvement in mortality outcomes. And indeed, the lower income patient is less likely to be seen. That's incredibly important for us all. I'll also point out another article from the American Society of Clinical Oncology that despite comparing those 340B hospitals, inpatient, outpatient, that for cancer care, the hospital-based care, which is associated with 340B payments, is associated with substantially increased cost. And another article, which I've lost in my mess, but which would say that under Medicare patients, Medicare Part B payments are 10.2% higher, again, moving beyond anecdote, 10.2% higher among the 340B entities because they are using higher cost drugs in a higher cost setting. So I do think it's important that we look at the academic data, which is objective, as we look at all this. You mentioned earlier, and just something to mention, Senator Hassan asked how many of the covered entities are audited, and did I hear you correctly, only 1.5% of covered entities are audited to make sure they're using the program correctly?
That's correct.
Okay. Now also, for the record, you just mentioned to Senator Casey the criteria by which someone could become a covered entity. But if you have someone that meets that criteria, who subsequently buys a, let's just say, cosmetic surgery practice in a very rich suburb of that city, and frankly don't see any Medicaid, Medicare, is that daughter site, so to speak, allowed to benefit from the 340B program?
So our standard for eligibility for sites that are off-site of the main hospital, for example, is that those clinics have to be reimbursable on the hospital's Medicare cost report for HRSA to consider them an integral part of the hospital and eligible for the 340B program.
And if they accomplish that, even though it might have nothing to do with poor folks or not see any Medicaid patients whatsoever, indeed doing cosmetic surgery, that they can benefit from the 340B program, getting the discounted drug, but then charging at the list price for that medication?
So if that site meets our eligibility requirements, then they would be able to participate.
Again, buying at a discounted rate, but billing at the normal rate
Yes.
for their cosmetic surgery patient. We actually posed that question to CRS, and they gave me the same answer, and I'll submit that CRS report for the record. I'm out of time, and our next person will be Senator Warren.
Thank you, Mr. Chairman. So, Secretary.
I have a second round now. I will start. Again, moving beyond anecdote, if you will, Senator Murphy quoted a GAO study, and I pulled up the summary of that study. And I think there's a couple other things to point out. Significantly, that, as we've mentioned in the articles that I previously quoted, 340B, according to academicians, incentivizes hospitals to prescribe more expensive medication and drives up costs for both commercial and for Medicare programs. That's important. Medicare is going bankrupt in 8 years. And we should be aware of anything which is driving up the cost for the federal taxpayer, but also for the patient, as she is paying a higher copay. All this is important. I'm just taking the perspective of what about the patient. Here we see, though, just to quote specifically, in 2012, the average per beneficiary spending at a 340B DISH hospital was $144, and DISH hospitals are 340Bs, was $144 compared to approximately $60 at a non-340B hospital. The difference did not appear to be explained by the hospital characteristics. It goes on to say, therefore, this is GAO, there is a financial incentive at hospitals participating in the 340B program to prescribe more drugs or more expensive drugs to Medicare beneficiaries. Unnecessary spending has negative implications, not just for the Medicare program, but for the beneficiary, who would be financially liable for larger co-payments as a result of receiving more drugs or more expensive drugs. I'll also say, as a physician, you're giving more drugs to somebody, you're more likely to have complications. And if the patient is our primary priority, we should not be overprescribing because we're exposing her to a greater potential for complications. I mean, that's just, bad things happen. And so, anyway, just to say, that seems to be the same GAO study that Senator Murphy was referring to earlier. So I do think that we have an issue. The rule that was put out by the administration, isn't it my understanding that that rule actually redistributed some of the benefits from the 340B program to rural hospitals? Are you familiar with that rule, Captain?
I believe you're referring to the CMS rule.
Yes.
As it relates to it. That's a rule under CMS authority and not under HRSA authority, so I
Are you familiar with it at all?
I am familiar with the rule.
You are familiar? Mm-hmm. Okay, and so, and with the technical, because my understanding is that that actually, so Senator Jones talked about 340B hospitals not doing as well, but it's my understanding that that rule redistributed benefits to rural hospitals. It was net neutral in terms of the cost to the program, but again, it just redistributed so that rural hospitals benefited more. Is that your understanding as well?
I'm not that closely familiar with the details of the rule, but I'd be happy to connect you.
I'm fairly confident of that, and so to Senator Jones's point, that would actually be a benefit of that rule. Now, you mentioned, and this I don't know the answer to, you mentioned that you've audited 1.5% of the covered entities and 28% of the manufacturers. What problems have you found among covered entities that we should be concerned about?
So with covered entities, we focus on their statutory requirements. Is first, that they remain eligible in the program when we audit them.
You had mentioned that earlier. So what are the issues that you have found? What percent of that 1.5% you've audited have had problems?
So in total, based on our audits, about 70% of the entities had findings. However, based on how we choose these audits, they are at higher risk for having findings. For example, we target audit entities that already have known issues, and we go in and audit to better understand what's happening on the ground.
So 70% of those whom you audited who are covered entities have issues, but granted, it's a select population. What about the pharmaceutical companies? What percent, and I'm asking, I don't know the answer to any of this, what is the percent of pharmaceutical companies that have issues? And by the way, going back to the covered entities, there's going to be a level of severity. There's going to be a grammatical error that you should have put a comma here, not there. And then there's some that are really significant. Is there any way, can you give us any kind of sense of whether these are significant issues or not significant issues?
They do vary across the board, from minor database issues to diversion of drugs to patients that weren't eligible. About 60% of the audits had required repayment to manufacturers. But again, even within that repayment, it might have been one drug that was found
Versus a lot. Now, what about, I'm almost out of time, what about the pharmaceutical companies? What percent of those whom you audited, are there problems, and what is the severity of the issues?
So we have not found issues in the manufacturer audits. Again, we audit based on that one core obligation to ensure they're charging the ceiling price, and we have not found any related to their statutory requirement.
Got it. Okay, I'm out of time, and I think now, Senator Murray, would you like to?